Welcome to Learning Module 7. This week we're going to be going over Chapter 9, which is the hip joint and the pelvic girdle. Now, what is the hip joint and pelvic girdle? Well, it is the hip joint, which is called the acetabular femoral joint. So if we have part of the hip, the acetabulum is the actual socket, and the femoral is the femur, and the head of the femur, which fits right into the acetabulum. It's a very, very relatively stable joint due to its bony architecture. If you look at it, the acetabulum, or the socket that it fits into, is extremely deep, and it covers the head of the femur very, very nicely. So it makes it a very stable joint. They have very, very strong ligaments that surround this joint too. The ligaments that surround this joint, you know, ligaments are bone to bone. So the ligaments that surround it are extremely thick, and from all the weight bearing, they get strong really fast, and they have to be stable to be able to hold this joint together for all the load bearing that this joint is subjected to. Next, it has very, very large supporting muscle groups. If you look at the glutes, the hip flexors, the quads, all that attached in this particular area, so they all surround that, because if we look at all the motions of this particular joint, we flex, we extend, we abduct, we adduct, we rotate, internal rotate, external rotate, and cut across these different planes of motion. It has to have these strong supportive connective tissue, muscles and ligaments, to be able to support it so we can do these movements most efficiently. Now, it functions in weight bearing and locomotion. So if you think about it, when we do ground-based movements, standing on our feet, we need it. Gravity's going through our trunk and it has to be supported in our pelvis. Without the pelvis being really strong and having those specific joints of the legs being really, really supportive and able to handle that load, we won't be able to function very well. It's enhanced significantly by its wide range of motion, which we just talked about. It gives us the ability to run, cross over, cut, sidestep, cut, jump, and think about all the endless motions that we do using the lower body. As the pelvis turns and the legs move, whether we run, jump, throw, squat up and down, bend, twist, all these are affected by that. So it has to be a relatively stable and strong joint. Now the bones involved, like I said, it's a ball and socket joint. We saw that before. Here's the socket, here's the ball of the femur, and it fits nicely into that ball and socket. The head of the femur connecting with the acetabulum of the pelvic girdle. Once again, we saw that. The pelvic girdle, we have the right and left bones joined together posteriorly by the sacrum. And the sacrum, as we know, it's the end. It's the 5 fused sacrum bones together that fit nicely. And here's the left side of our pelvis. And here is the sacrum that's joined together. It holds together. Now that where it joins at is considered a joint. It doesn't move very much, but just enough to give us some flexibility in there so we can move more efficiently. Now the pelvic bones are the ilium, the ischium, and the pubis. We also have the femur, which is our thigh bone, and it's the longest bone in our body. So if you look at the diagram, you'll see the whole pelvic girdle, all 3 bones plus the sacrum as well, and then the femur as it connects into the acetabulum. Now the sacrum is the extension of the spinal cord, as we said, with those 5 fused vertebrae. Extending inferiorly is the coccyx right here. So it comes in inferior. It's inferior when it extends inward. Now the pelvic bone, I said, is divided into 3 areas. The upper 2/5 is the ilium. Let me put these down. The upper 2/5 is the ilium. The posterior and lower 2/5 is the ischium. And anterior and lower 1/5 is the pubis. Now what are our bony landmarks here? On the anterior pelvis, we have the origin of the hip flexors. So that's the anterior portion of the pelvis. Those where all of the hip flexors are located. We have the tensor fasciae lata, which is on the anterior iliac crest on the top. The sartorius is on the anterior superior iliac spine, right here. And we have the rectus femoris. It's part of one of the quad muscles that not only extends the knee, but also flexes the hip. And it's attached to the anterior inferior iliac spine. Continuing on with the bones, let's look at some more bony landmarks. If we look at the lateral pelvis on the outside, so if we look at the acetabular pointing away on the outside, the lateral part of the pelvis, it's the origin of all the hip abductors. Abduction is out to the side, away from the midline. And this would be the gluteus medius and minimus, just below the iliac crest on this side. Medially, on the inside toward the midline, is the origin for the hip adductors. So that would be the adductor Magnus, adductor Longus, adductor Brevis, the Pectineus, Gracilis, and the pubis and pubis and inferior ramus. Now posteriorly, it's the origin for the hip extensors. Anything to extend the hip. That would be the gluteus maximus on the posterior iliac crest and the posterior sacrum and the coccyx. So if we put these together, let me do it here. If we do that on the back side and this, so on the back side, the gluteus maximus on the posterior iliac crest and the posterior sacrum and coccyx. These were all where the hip extensions would attach to. Now posterior inferiorly is the origin of the hip extensors. That would be the hamstrings on the ischial tuberosity. On the ischial tuberosity, back here. That's the ischial tuberosity on the backside. That's where the hamstrings are attached at. Now the proximal thigh is the insertion of all the short muscles of the hip. So we look at the gluteal muscles and most of the 6 deep external rotators on the proximal thigh. On the back, the upper part of it, the insertion of all the short muscles. There would also be the iliopsoas, which would be on the lesser trochanter. Here's the greater trochanter. Here's the lesser trochanter. And the proximal thigh origin of the 3 knee extensors. The 3 vasti muscles are the quadricep muscles, anteriorly on the front side of the femur. There's also where the hip adductors are, the linea aspera on the back side, right in here. On the patella, where the kneecap is, the patella is right in here, the very end of the femur. If we look at that, right at the very end, the patella, it's the insertion of where all 4 of the quadricep muscles do. You got the patella right here, it crosses over and attaches down on the tibia. Proximal tibia or fibula, right here, the insertion of all the remainder of the hip muscles as well. We have the sartorius, the gracilis, semitendinosus, which is the upper anterior medial tibia on the medial side, just below the medial condyle, which is right here, medial condyle. After crossing the knee posteriorly medial, on the back side toward the mid side. The semimembranosus also too attaches on the medial side, posterior medially on the medial tibial condyle. Medial tibial condyle. So if you look at it, you have on the back side, medial tibial condyle, the hamstrings would attach to the ischial tuberosity, come down, semimembranosus and tendinosus attached down on the medial side. The bicep femoris attaches on the other side. So we have 3 hamstring muscles attached posteriorly, which flex the knee. Now the proximal tibia or fibula, that's the insertion for the remainder of the hip muscles. Which I said, I talked about the biceps femoris. Laterally, primarily on the fibular head. Remember, you got the tibia and the fibula, with some of the fibers attached on the lateral tibial condyle, which will be on this side right here. The iliotibial tract of the tensor fasciae lata, it flexes the hip, and it's anterior-lateral on Gerdy's tubercle of the tibia. Now for the joints of the hip and pelvic area, for anteriorly on the front side, we have the 2 pelvic bones that are joined together to form the symphysis pubis, and it's an anti-arthroidal joint. It doesn't move very much. So if you look at it, if you get the 2 ischiums and ilium, the 2 pelvic joints, as they're joined together, they're joined here at the pubis. Right here. 2 sides joined right here at the pubis bone. Now posteriorly, we have the sacrum is between the 2 pelvic bones and forms the sacroiliac joints. Now there's between here, the sacroiliac joints, very, very strong ligaments, and they unite these bones to form a very rigid but slightly movable joints. So if you look at the movements there, and we're going to go into this, even when we walk or jump or anything, those joints will move just a little bit to help position the socket in the right place. Now these are large and heavy bones. They're covered by thick, heavy muscles. There's very minimal oscillating. It doesn't move back and forth very much. They don't move hardly at all. And they occur in the sacroiliac joints, such as walking. And all body movements usually involve the entire pelvic girdle and hip joints. So even when we're walking, when we flex, what happens is the pelvis will rotate. The knee will come up, and as we extend out our leg, it'll rotate and then extend the whole joint. So it's always going. It's either going forward or backwards, up to the side and down, or rotating backwards or forward. Both sides. In walking, we have hip flexion and extension occur with the pelvic girdle rotation, as we just said, forward in hip flexion and backward in hip extension. So once again, in walking, hip flexion and extension occur with the pelvic girdle rotation. It's going to have to rotate to position that leg to go out. It's going to go forward in hip flexion and backward in hip extension. Now, jogging and running result in faster movements and a greater range of motion at the hip joint. Pelvic rotation increases the length of the stride in running and in kicking, and it also results in a greater distance or more speed. So the pelvis has to rotate. You just can't do everything from the hip joint. If you have accessory movements there, because if you look at swinging a ball bat, it goes, the pelvis moves first, so the body will follow. Same with running. As you come up here, the pelvis isn't going to move. It has to rotate, it has to move up to the side, rotate forward, so you can go forward in that particular stride movement. Watch a sprinter when you're doing that. As they go back and forth, as they rotate their upper body one way, the pelvis goes the other, and back and forth. But it has to, because it's trying to position that leg in the most appropriate place so we can get faster and longer strides. Now the acetabulo-femoral joint, it's one of the most mobile joints in the body, except for the glenohumeral joint. We already looked at that. You know, the socket's very shallow, but it has great range of motion, but it's very unstable. It's mobile, but not stable. Now it's a multi-axial arrangement. In other words, it does a conical movement. So it goes and it's multi-axial, means it moves through 360 degrees and it goes through all three planes of motion. And the bony architecture provides the stability. Once again, let's look at that. If we look at that, just like that, if we look at it, it's extremely stable joint. The socket is pretty deep, but the head of the femur is is big as well. So in there, it can cause a lot of movement. It also provides a substantial amount of stability because the socket is so deep. Now, there's very few hip joint subluxation or dislocation. You hardly ever hear of anybody dislocating their hip joint. It's an inarthroidal type of joint, and the femoral head inserts into the acetabulum, as we've seen, and it's reinforced by strong and dense ligamentous capsule. It's got a big capsule on there, especially anterior. So the front part of the acetabular femoral joint has a very, very strong, thick capsule on the front side. Now, this joint, it's got an iliofemoral or Y ligament configuration. It's located on the front side of that joint, and it prevents hyperextension. So you can't extend because when you try to extend the leg, you can't hyperextend because of this. What it's going to do is tighten up and prevent it from extending too far back. The pubofemoral ligament, located anterior medially and inferiorly, exhibits excess extension and abduction. Excessive extension and excessive abduction, because it'll tighten up and hold it there. Now we have the Teres ligament. It attaches from deep in the acetabulum to a depression in the femoral head, and it slightly limits adduction this way. So if we look right inside the acetabulum, there's a ligament that's attached to this groove or this depression right here in the femoral head. So you can see in the picture too. It attaches there and it holds it in there and slightly limits adduction. As the leg comes in, it slightly limits that. It's similar to the glenoid fossa of the shoulder joint. The acetabulum is also surrounded by a labrum, a lip of cartilage that surrounds that for more stability. And it also provides some shock absorption as well. Now the ischiofemoral ligament, right here, ischiofemoral ligament. It's located posterior on the back side and extends from the ischium to the trochanter fossa, right on this side in here, on the back side, the fossa of the femur, and it limits internal rotation. In other words, you can't internally rotate your leg that much. Because if we look at it here, and if we go to the back side, it's right in here, so it attaches from here, goes over to here on the inside, and it limits internal rotation. Internal, which means that this is the, excuse me. Sorry about that, kids. So if this is the left side, we do internal rotation, and we turn our leg inward. It's going to, that ligament is going to limit that particular type of movement pattern. Now there's some disagreement about all the exact possible ranges of motion in the hip joint. Some say it's from 0 to 130 degrees. So we're going to look at that. So if you're laying on your back with your leg straight out and you pull your leg up, the hip joint is going to have approximately from 0 to 120 to 130 degrees of hip flexion. Now if you turn upside, if you turn with your face down, if you pronate, you can extend the leg. It goes anywhere from 20 to 30 degrees. So 0 to 30 degrees of extension and 0 to 130 degrees of flexion. So those are your ranges. Now, if you're laying on your back and you abduct the leg, we have about from the midline from 0. Abduction is about 35 degrees. Adduction is 0 to 30 degrees. 0 to 30 degrees. So let's look at adduction. 0 to 30 degrees. From 0 to 30. It says 20 here, but once again, if you have to look at what textbook you're reading, so there's going to be ranges. So it says 0 from 0 to 20 to 30 degrees adduction, 0 to 35 degrees abduction. Now if we look at internal rotation, if we internally rotate this way. Now, the foot goes outward, but the leg is actually rotating inward. So that's 0 to 45 degrees. Now it's 0. Now if we externally rotate, the leg is actually rotating to the outside, but the foot goes inside. So that's 0 to 50 degrees. Now the pelvic girdle moves back and forth within all 3 planes of motion and has 6 different movement patterns. And all the pelvic girdle rotation results from motion at 1 or more locations. So we're going to take a good look at that. It's going to have the right hip, the left hip, and at the lumbar spine. So right hip, lumbar spine. Now the next slide is motions accompanying pelvic rotation. So here's a graph, and we're going to go through each one of these and show you exactly what's happening. So on one side we have pelvic rotation, then we have what's happening with the lumbar spine, and what's happening at the right hip, right and left hips in all these different motions. So we're going to look at anterior, posterior tilt, right lateral, left lateral, right transverse rotation, and left transverse rotation. We're going to go through each one of these to show you exactly what's happening. Now, the next movement, we're going to look at right and left pelvic rotation. And here's where it can kind of get confusing a little bit. Now, we're going to look at pelvic rotation. This is in the frontal plane, lateral frontal plane. Remember, sagittal plane, frontal plane, transverse. So we're looking at moving in this plane of motion here. So what I'm going to do is turn around and try to match that. That's looking at the back side of my pelvis, or the glutes. So the next one, if I do a left pelvic rotation, left lateral rotation, that means if I don't move anything else and I just move my pelvis to the left, I'm going to do this. So if we look at that, my pelvis, the right pelvis is moving up, the left pelvis is moving down. So I'm just doing that. Looks kind of funny, but let's look at this. The left hip is abducting. The top of it's moving away from the midline. So I'm doing this. The right hip is adducting. That means the top of the hip is moving toward the midline, and I'm getting right lumbar lateral flexion. If I do it the other way, if I do right lateral pelvic rotation, all right, it's abducting, it's moving away from midline. The top of the left is moving toward there, and I'm going to get left lumbar flexion. So it can be kind of confusing. Let's add insult to injury for the next one. Okay, right transverse clockwise pelvic rotation and left transverse counterclockwise pelvic rotation. So if the left moves, that's going counterclockwise. If I move right, that is clockwise. That's in the transverse plane, or horizontal or transverse plane. Sorry, Mr. Skeleton. So if I look at left pelvic rotation, so I'm going to move my pelvis left. I'm going to move it clockwise. That's accomplished by my left pelvis is going to internally rotate, my right one is going to externally rotate, and I'm going to do right lumbar rotation. In other words, the right lumbar is going to contract and rotate. Pelvis moves one way, the upper body tries to move the other way. So that's left transverse rotation, right transverse rotation. Left, right. You get a little dance for you there. Now, let's look at the regular movements of the hip joint. If we decrease the hip joint for the thigh, if we pull our leg up, it's decreasing the angle, so that is flexion. That's what flexion is, decreasing the angle at that joint. Movement of the femur straight, anterior forward toward pelvis. So we take this, moving it toward our pelvis, because remember, that motion is circular, so it's trying to move this upward toward the pelvis. Hip extension, move the leg down in the neutral position and move our leg backward. That's working the glute. This is working the hip flexors. This is working the hip extensors. Movement of the femur straight posteriorly away from the pelvis, sometimes referred to as hyperextension. So flexion, extension, hyperextension. But we just call this extension. Hip abduction, as we know, we're just taking the leg and moving it away from the midline, away from the body. Moving the femur laterally to the side, away from the midline. And guess what hip adduction is? Moving the leg toward the midline. Pretty simple. Hip external rotation, taking the whole leg and rotating it outward. If you look at your foot straight ahead, you're moving it away from the midline, externally. External rotation. Hip internal rotation, you're taking your foot and rotating the whole leg inwardly. Inwardly. The heel moves out, but the toes moving inward, but the whole leg is moving at the hip. Hip diagonal abduction, taking the leg and just moving it outward away from you. Moving the femur in a diagonal plane away from the midline of the body. So away. What's hip adduction? Moving it toward here, across the midline. Now if we look at hip horizontal abduction, moving the femur in a horizontal or transverse plane away from the pelvis. So we're bringing it up here and we're moving it away from the midline. For abduction, we're just moving it toward it. So we flex, move it away in a horizontal plane, away. That's abduction, toward the midline, adduction. We looked at this before. Anterior pelvic rotation. Anterior movement of the upper pelvis. We're moving it forward. The iliac crest tilts in a sagittal plane, they call the anterior tilt, and downward rotation of the upper part. Downward rotation. And the pelvic rotation, posterior movement of the upper pelvis. So we go from here, try to push it backwards. The iliac crest tilts backwards in a sagittal plane as well. Posterior tilt, upward rotation. We looked at lateral pelvic tilt. In the frontal plane, the left pelvis moves inferior. Relation to the right pelvis. See, the left pelvis rotates downward, the right pelvis moves upward, or vice versa. Left and right. Right pelvic rotation, in the frontal plane, the right pelvis moves inferiorly in relation to the left pelvis. Either right pelvis rotates downward or left pelvis moves upward. So, left, right. Transverse left pelvic rotation. In the horizontal plane, pelvis rotates to the body's left. We looked at that before. Left, left, right. Right iliac crest moves anterior in relation to the left iliac crest, which moves posterior. In the right pelvis rotation, same thing, just the opposite. We got left, right. Now, if you look at the muscles, there's 7 two-joint muscles that have one action at the hip or another at the ankle. So a lot of these muscles are two-joint muscles.